persistent hoarseness, so any changes to your voice, that's a massive red flag. Your pain on swallowing is a bit of a concern, not a massive red flag, but your weight loss is also a red flag. And then, as someone mentioned, fatigue that's also included in your B symptoms that you have with red flag symptoms. So, in terms of the red flags, so according to NICE, the things that you want to look out for in this patient is we've already explained. So, the neck lump, which is over 3 weeks, and it needs to be unexplained. So, unless they've had specific trauma to area or there is a specific medical condition that might cause a neck lump that you're already aware of, anything unexplained is definitely a red flag for referral. The hoarseness, so any changes with your voice, um, is always a red flag and is always something a GP will uh, be scared of. Your weight loss, which is part of your B symptoms, and then you have your odynophagia and dysphagia. Your dysphagia is more to do with a mechanical obstruction in your throat, and your odynophagia is to do with your voice production. And then anything to do with otalgia, um, so any ear pain or ear pathology with normal otoscopy is typically a red flag. And then that's basically due to the fact that you're looking at particular cranial nerves that might be involved. Um, yeah, but in terms of the voice changes, the ones that you want to look out for is if it's a hoarse voice, which we'll cover because that's a specific cranial nerve involved. If it's breathy or weak, that can indicate some specific neurological cases. So, like myasthenia gravis, you can have some voice changes, but again, red flag. And that's also to do with fatigability as well. And then your systemic symptoms, so as someone mentioned, fatigue, you can have weight loss, night sweats, and then anorexia. And then one other thing you want to look out for is any previous treatment. So anything like chemotherapy, radiotherapy, or anything that might suggest that they're immunosuppressed. So, in terms of the further history, um, we're going to assume that there is no family history of um, cancers at the moment, but you find out that they've had a 40-pack year smoking history and they drink an excessive amount of alcohol and they haven't had any infections or dental issues. So if we're looking at, sorry, it's a bit of a jump here, specific differentials, what would you think about? So to recap, there's someone who has a change of voice, uh, B symptoms, so fatigue, weight loss, and he's had a neck lump for over 3 weeks, or in this case, he's had it for 6 weeks, and he's a middle-aged man. And I'll just look for three differentials.
Someone said reactive lymphadenitis,
Mm-hmm.
laryngeal cancer.
Mm-hmm.
Someone said these are risk factors.
Mm-hmm. Okay, I'll cut it there. So your differentials, it can be extremely exhaustive, but in terms of your red flag ones, uh, uh, laryngeal cancer. So in this case, I've specified squamous cell carcinoma. You can have a lymphoma. So um, anything that comes up with lymph nodes swelling around the neck or around the uh, upper limbs, you always want to think of lymphoma. Thyroid cancer is also one as well. You'd want to go through systemic features, which I didn't cover too much, but that's also something. Your salivary gland malignancy, which is also rare, and then you can also have things like infection. So TB is one, HIV is one if they're immunosuppressed, and then the reactive lymphadenopathy or lymphadenitis. Um, that's also a really good differential, especially if someone's recently been ill, because you can have any lymph node enlargement anywhere after a recent illness. So, in terms of the um, examination, so what this GP did was he examined the patient and he referred for further imaging. So he sent him to the hospital. So these were the results. So he noticed a 3 centimeter firm, non tender uh, left lymph node enlargement. I'll go through what the different levels are. And when they put a camera up his nose, they found that there was a lesion on the left supraglottis, and they've noticed some reduced mobility of the left vocal cord. So, in terms of the anatomy, you have around 6 different areas of your neck, which each parts um, is responsible for different drainage. Unfortunately, there isn't a mnemonic to remember this, but the best way to look at this is when you first practice your clinical skills. I don't know if you guys have done it yet, depending on what year you're in. Um, you'd ideally want to follow exactly what this diagram says in terms of 1 to 6. And in that way, whenever you're presenting your findings, you can then identify where exactly or which triangle is involved in the um, swelling. So in this case, I always start off with underneath your mandible, which is 1, and you want to go straight to your SCM. Once you go down, so you have the top bit, which is 2, you go down to 3, which is your middle bit, and then you go down to 4, which is uh, the bottom bit of it. 5, you kind of want to go backwards, and then you kind of want to end up at the front of your throat to move down in terms of to your clavicles. Um, that's something that you'll learn when you do clinical skills, and it's what we were taught was this is one of the best ways to do it because you cover systematically each area of uh, your lymph nodes in terms of the triangles and angles, and then that makes it easier to document your findings. If you look at anything in terms of um, up here, you it's very rare to get some swellings, or in this patient at least. Some ENT presentations can have swelling in 9 or uh, sorry 9 or 8 here, but in this case they're a bit irrelevant, and they'll have a completely different presentation. Uh, and then if we go into more of the anatomy, I've kind of just left the diagram here just to say how complicated the anatomy around the throat is. So you have the trachea, the cricoid, you have your vagus nerves around the area. So whenever you're thinking about changes to specific functions around the throat, you always want to look at specific nerve involvements, anything to do with any skin changes. Also, think of specific vessels that might be involved. And the importance of the left sided, if we go back, the left-sided lesions and ulcerations and the lymph nodes, one thing to always look out for is the left laryngeal nerve. I'll go through that a bit later on. And this is your vocal cords. So typically, when you're speaking and talking, it's opened, and then at rest, it's closed, and that just stops any. So it stops any fluid or anything to go down and causing aspiration. So it's going to be a bit hard here, but if I asked you guys a level 2 lymph node, um, why would that be significant for someone? If also, what sites does the level 2 lymph node drain? And then in terms of the problems that they've seen in terms of vocal cord immobility, why would you think that is? And then what I'll do here is the level 2 lymph node is just up here, and to help out, we're looking at this area here for level 2 lymph node. So if I just ask you those questions in terms of why is that a bit significant or a bit of a worry in this scenario when you were looking at this area of the anatomy?
Someone said potential laryngeal nerve invasion,
Hmm.
or maybe because it's close to like the blood vessels, I guess.
Hmm. If not, that might be a bit of a tricky one. It's either something you know or don't know.
Someone
So
said impacts the ability to speak due to nerve
mhm.
impairment.
Yeah, so that's exactly what it is. So the fact that it's a left-sided, we're looking at the nerves involved. The reason why you don't want to think about any of the blood vessels yet is because there isn't any weakness or any skin changes that you've noticed with the swelling. So the drainage, this isn't particularly high yield, especially in specific exams, but it drains your oropharynx, your oral cavity, your nasopharynx, hypopharynx, larynx, and parotid and cutaneous areas. And as I mentioned before, the level 2 is literally just at the top of the SCM muscle. One thing to always think about first is this drainage usually follows this sort of pattern. It goes around from 1 to 6, but just because you have a lymph node in 2 doesn't always necessarily mean that 1 has to be affected. I'll go through that in a second. So this is a bit of the anatomy here. So your superior laryngeal nerve is a branch of your vagus nerve uh, that moves down and then splits into your superior laryngeal nerve. Sorry, where's my mouse? And then your recurrence, which kind of goes downwards. Your superior laryngeal nerve is divided into your internal branch. So your internal branch is this top bit up here, and then you have your external branch, which basically innervates outside, internal, inside. Um, your internal branch is the provides your sensory innervation, usually above the vocal cords, and your external branch supplies motor. It gives motor supply, especially to the cricothyroid muscle, and that's important because it tenses your vocal cords, which controls the pitch of your voice. So in this case, for this patient, because he has a lymph node, there's swelling, it's impinging on this area here, especially the external branch, which causes him to have a bit of a hoarse voice, and then which is why on endoscopy, part of the epiglottis um, had poor mobility. And then you have the recurrent that also comes down as well. And then, as you know, the left-sided loops underneath the aortic arch, and then your right-sided, which other side goes down, loops around your right subclavian artery. Um, and this recurrent branch, sorry, innervates all of the intrinsic laryngeal muscles around the area. It's just this area here provides motor supply to the cricothyroid. So that usually comes up in a lot of exams. And the clinical relevance of this is when you're having, for example, a thyroidectomy, you can always lacerate these nerves, which can cause your vocal cord paralysis, especially if you're cutting the external branch here. Um, and then even if it's further behind it as well, any of these branches from the recurrent laryngeal nerve as well can cause hoarseness of your voice. And then for your thoracic surgeries, your left does loop around your aortic arch, so can cause damage, which then impacts your vagal supply to the area in your chest as well. So, although so far we've spoken to the patient, we found out the history, we've done a bit of an examination, and then we found out this is something that is very significant. So referred him to the hospital, and now we're going to pretend we're part of the ENT team. So, what would you do first? So, you've already seen someone with an endoscopy, a nasal endoscopy. Um, the lesion, would you want to biopsy it first, or would you like to image the area first? And it can go both ways.
Imaging.
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 Anyone want to do biopsy?
Yeah, I'll go for biopsy. Sure.
Okay. When you first get this patient and you refer them, it's part of your triple assessment. So any type of malignancy or cancer, it follows a triple assessment, which is a clinical assessment. So, and that can literally just be your lymph node examination. You have your imaging that comes first, and then your histology. So, in the past, I believe it used to be histology first. So, once you first saw it on your nasal endoscopy, you can then biopsy it first, but because of recent changes in imaging, that's kind of surpassed it first. So, in terms of your stepwise approach, you want to do an ultrasound of the neck and then also do a um, fine needle aspiration just to check the cytology. And then you can also have imaging. But however, because we've only felt one lymph node, we don't know exactly if that's the main site or if that's a secondary site, perhaps where it's spreaded from an original area in the throat or from somewhere else. So nowadays, what we do first is we might ultrasound the neck to find out if there's to look at the lymph node and just to see if there's particularly anything that we've missed, because there's always human error. Um, but nowadays we use PET CT scans, and that literally highlights any swelling in the neck, which then can help you with this histology, or in this case, a fine needle aspiration. So you can then pick different parts of the tissues of the lymph nodes, and then grade this swelling, and also to then limit down your differential so you know what you're dealing with. Yeah, so there's also, again, they're all different names. Your pan endoscopy, so we've kind of like looked at that, where you can look at the lesions directly if it is within the mucosal area. Sometimes, if you do want to have a bigger picture, you can have a tonsillectomy or um, taking a biopsy from the base of your tongue just to see that as a starting place before it moves anywhere. And then tonsillectomy basically removes the tonsil so you have a greater view of the area just to see if there's any spread to other areas in the neck, and also to preserve the tonsils because it can typically get affected first. Um, and yeah, so your biopsy, it used to be in the past, but not anymore because it's quite invasive. And then you can always nick very important structures in the neck. So it's kind of ruled out. So your PET CT is first as part of your imaging, and then your fine needle aspiration would then be part of your histology right after. And then this works in all different cancers, so even breast cancer as well. You have a feel of the lump, you image it with either like an ultrasound or a mammogram, and then you have your histology to determine what cell type you're dealing with, and therefore what uh, disease you're dealing with at the time. So in this case, he's had a PET CT. and or a CT neck, and he's had a histology. And what we found is that with a normal CT, we've had a supraglottic mass, and only one side, so one side of the lymph nodes are impacted. The histology says it's a squamous cell. So linking back to whoever said about laryngeal cancer, and your PET CT, um, which is your very niche um, imaging, detected no metastasis, so no spreading of the cancer to extra organs. So in this scenario, in many cancers, they follow something called the TNM criteria, if you've heard of it. So your T stands for tumor, which uh, how do I describe this fully? It goes through it like a stepwise manner. So when you have a swelling, you want to look at or a tumor in this case, you want to first identify the main features of it. So your T will always involve the size of the tumor. So in this case, this is like the TNM9 criteria. So this works for all head and neck cancers. Um, you give different scorings due to how big it is. So T1 would be something that is central, kept to the location. Two is something where it might touch nearby structures. Three is where it starts invading other cell types or other key features. So your cartilage and then your vocal cords as well. So the impacting the nerves here. And then you can have 4A and 4B. That literally just means how much has it spread. Some cancers typically have a better way of defining these. So they might literally have specific centimeters that they have. So I believe in specific bladder cancers, they have it where it'll be like 3 centimeters and then 4 and then 5 and etc. Your N stands for your lymph nodes, or just nodes in this case. And this kind of just determines how far or the potential of your lesion, or in this case, your SAC, can spread. So that kind of just goes into A, if it's one or multiple lymph nodes, and then B, if it's how big it is. So in this case, your N1 has one lymph node, which is less than or equal to 3 centimeters, and then you have a 2A and 2B, which is again, your A would mean that's ipsilateral, single, and then your B would be multiple ipsilateral. And then your M, which is just a case of 1 or 0, just tells you whether or not it's metastasized, which basically means has it gone to any other organs or any other structures, such as like the bone, for example. And that's important because all of this determines how you then treat the patient. So another thing we can look at is something called field cancerization. So if we went back and when we first took their history, we noticed that this person is smoking and this person drinks alcohol, which is a massive risk factor for literally any type of cancer. But field cancerization is a very specific terminology that's used in, I think it's a matter of 3 different cancers. So essentially what it is a exposure to a particular carcinogen, which then can have specific changes in a cell type, so a malignant change in a cell type. So in this case, it's the the upper airway. Other things to look out for is like things like skin cancers. So you might know already, specific skin cancers, UV rays are like a massive risk factor. And if you think about it, the only way you can get specific skin cancers is if your skin or your face or whatever is exposed to UV, which then means that your whatever is exposed or that field can ultimately be at risk of cancer. Um, so that's one way. That's one area. So your skin is one, your bladder is one in terms of specific dyes. So it's the dyes which are carcinogenic can store in your bladder, which then can cause any changes in terms of your bladder cells, which then increases your risk of cancerous changes. And then in this case, smoking, because of how long the smoke and the carcinogen stays in your upper airways, increases your chance of malignant changes, or even pre-malignant, which then can go into malignant changes. Um, and it literally spreads from your lips to oral cavity, pharynx, larynx, and then upper esophagus. And the reason why, in this case, is a squamous cell carcinoma is because this whole area is lined by squamous epithelium. So I made an image here just to go through what you would kind of see on the your triple assessment. So on your CT neck, you would see your subclonic tumor kind of show up here with your lymph nodes on the side. As we mentioned, um, if you can feel the lymph nodes, then it's going to be on the um, outer side of your CT scan. So in this case, it should only be two instead of multiple. Your histology, your squamous cell carcinoma will come up, um, and I forgot what the stain is, but you can put a specific stain and detect it that way. And then your PET CT scan could then identify um, very fast differentiating cells. So any metastatic cells. So in this case, it will only show up one bright area, which is your main SEC that you're looking at. And then sometimes you can see it where it goes to the bone, or I mean, it's very rare to go to the brain, but it can go to the bone or into the lungs um, if he's still exposed to specific carcinogens. And going back to the um, history, the reason why we also ask smoking history together is because it has a synergistic effect. So although he did smoke 40 packers, if we ignore the 30 units, it's still a massive risk. But because it's with alcohol, they both increase their carcinogen effects. The specific underlying etiology is a bit unknown at the moment, but that's why in social history you ask both of these, and typically if both of them are quite raised, that will definitely increase your likelihood of putting cancer as a differential, which is you always right in OSCEs. So in this, so we went through TNM's components. If we spoke about local regional disease, so in this case, he's only had one or two lymph nodes that are enlarged. What would local regional disease mean? And also, due to the fact that we've noticed that he's had a large tumor, he's had two lymph nodes involved, and there's no metastases. What would you guys think of his prognosis? And then what would you think his treatment would be for this?
Just waiting to see if anyone messages.
No problem.
Local regional disease refers to cancer that's confined to the original site and nearby or lymph nodes.
Or like another question I can ask is, if it was local regional, uh, or if it did metastasize, w- what would your prognosis be for the patient? So if he did have a metastases versus if he didn't have a metastases.
I mean, the more it spreads, generally the worse the prognosis, right?
Mhm. So in this one scenario, local regional is basically just the fact that the tumor or the swelling is defined to a particular area. So it's only a primary tumor site, meaning that it isn't a spread of it from a different area in the throat. The fact that it affects only lymph nodes close to it, and the fact that it doesn't have any mets. So in this scenario, it's more curable because you're not dealing with any other structures at all. And the staging matters in the case of whether or not you want to cure the patient, or in some cases, palliate the patient. Other things that you can do is your single or multimodal treatment. So if we went back to local regional, you might have a particular treatment that you might give to the patient, but if it did come from a secondary site within the throat or a secondary site within the head and neck, that would then involve a multimodal approach. So you might have two or three different treatments that you can give for it. Um, and then your staging, it matters in the sense of your TNM, because you want to look at whether or not you can preserve that area that's effective, so your organ preservation as well. Um, so going through it a bit more, um, we mentioned that the vocal cord was slightly affected, which then would mean that it's quite a advanced car- cancer. So in this case, it can be a T3. So we mentioned that I believe it was a T2 that they picked up. But in this case, because there was some uh, impact on the mobility, it's showing that it is progressing quite quickly. And if we don't act now, then it can further spread into other areas. Um, when we look at other things such as the T4, which I mentioned earlier, once it invades the cricoid or thyroid itself, that basically destroys the area, which then means you actually have to remove uh, those areas so that it doesn't further spread or causes further damage. Um, and I think that's it for this slide. So in terms of your MDT and your follow-up, um, because it's a local regional disease, your main approach is your chemoradiotherapy. Um, there are different ways of going around this. Your chemoradiotherapy just targets the massive tumor and the lymph nodes affected. Um, but one thing that you can also do is, which a ENT reg mentioned, is because if we look at this area here, because it's still confined to one area and only a few lymph nodes are affected with no metastasis, you can do a surgical approach, um, because the tumor hasn't invaded any supraglottic structures. So you can do surgery with a bit of chemo, or just have chemo in the scenario. And so, something you want to talk to the patient is the risks of having surgery, talking specifically about any damage to the nerves, blood supply to the area, or nicking of the thyroid itself. So when you're talking about these specific things, you want to look at your MDT. So you have your ENT or OMFS surgeons, oncology, radiology and pathology, SALT, which is your speech and language therapists, your dietitians, and then palliative care if you need. But in this scenario, he's not palliative. And the things you want to look at are things like their dysphagia, their voice preservation, their nutrition before and after their surgery, the impact it's having on that patient because of um, a change of voice, and then your risk reduction as well. So I kind of went through this a bit, but if you wanted to go over this scenario, so the consultant has picked chemoradiotherapy. Why would you pick chemoradiotherapy over surgery in this patient specifically? And then what complications would you then talk um, to the patient?
It preserves the larynx.
Mhm. And then what complications for chemoradiation or chemotherapy would you look at as well?
Mucositis.
Okay, yeah. Um, so the answer, so the mucositis is like your number one thing, but in terms of why the consultant in this scenario picked chemoradiotherapy, is the fact that you can preserve the larynx. It avoids any unnecessary surgery, so that's something you want to talk about to the patient. Um, if surgery is your definitive approach, then you can stick with that. But the fact that they might have surgery and radiotherapy again, some patients might not like that. Your chemoradiotherapy would then start first because it maintains your voice. There's less of a risk of lacerating the laryngeal nerve if you are doing surgery, and the fact that the in the TNM stages, the fact that it was T2, so it was around the supraglottic structures and not a T3 T4 where it's starting to invade the supraglottic structures or the cartilage itself. You can just focus on chemoradiotherapy, but that can also be a strength for why you want to do surgery. But again, with the laryngeal nerve and with the blood vessels around it, you don't want to nick those at all. Um, and in this case, why you want to do it is because of the fact that when we look at NICE, which we always have to look at, you always just want to look at things that preserve your organs. So when you're doing your surgery, you might have to remove parts of the thyroid to have better view. Um, and there can always be loads of complications around just having surgery. But in this case, with chemoradiotherapy, just having this one treatment, you just need to go through the main complications. So um, it goes into this order in terms of what you want to talk about. So you have severe mucositis. So it becomes you're using specific radio waves and specific chemotherapeutic drugs. It irritates a lot of your mucosal surfaces, um, and because of that, it can cause different features, which goes down the list here. So you can have your dysphagia, your xerostomia. Um, because you're still shooting beams, it can affect your thyroid, which then can cause your hypothyroidism. And that's something to remember because your hypothyroidism, you can have radioactive iodine, and then having too much can cause hypothyroidism. Um, you can have specific necrosis or osteoradionecrosis, again, to the bones as well. It's affecting any structure that's around the area. Your voice impairment, that can just be due to inflammation around the area, and then your feeding tube dependence, which would then result of all of these complications combined, which would then impact their ability to swallow, especially with your dysphagia. So, in terms of the take home point, sorry, it's a bit rushed here. Um, if you ever have a long standing neck lump, which is persistent or unexplained, you always want to think of malignancy. When you're thinking about head and neck cancers, your main type of cancer you're looking at is their squamous cell carcinoma, just purely because of it lines a lot of the areas in these area, a lot of the areas in this region. Um, your supraglottic tumors always spread early via the lymphatics, just like in this case. Your nodal disease can worsen your prognosis due to the spread around the area. Your TNM staging helps to guide your treatment. So in this case, whether or not you want to stick with chemo, radiotherapy, or surgery, or palliative. Um, in this case, we did chemo radiotherapy, which fits into the nice guidelines of organ preservation. And in terms of the follow up for general head and neck cancers, it's around 5 years. It used to be lifelong, but they just changed it recently to 5 years. So you get seen every 2 months for the first 2 years, every 3 months in up until your third and fourth year, and then your fifth year you get seen just twice. And the reason for that is when you first start off your chemoradiotherapy or with your surgery, you're going to have complications arise very quickly in the early parts of your recovery, and then your body will kind of get used to it as years go on. And then these are my references, and that's it for today. And I'll stop sharing my screen.
Thank you, John, for the session today. Let me just send out. Great. So the feedback form is now sent in the chat. Please do fill it out, and then you get your certificates as well, and discount codes from our sponsors. Our next session will cover neurology and your surgery, and that's next Tuesday and next Thursday at 7 p.m. And we'd love for you to join us again. And please make sure to follow our social media platforms, and the links for this are available in the chats. And please also do check out our website. You can have access to the website, the previous teaching series, the PowerPoints, and the links to these videos. And of course, do put in your chats, your questions in the chat. Roberto asks,
Mhm.
oh, there's a question related to last week's session. Okay, I'll go back to that later on. Zaz Mohammed said, when would surgery be more appropriate than chemo?
So in to so in today's medicine, if it was a very early cancer, so if the tumor size was quite small, no, actually, um, in terms of surgery, it in today's day and age, it depends on the surgeon itself. So whether or not they're very qualified or very experienced. Um, as a general rule of thumb for as a medical student, if it's very big, so if it's a T3, T4 or above in this scenario, you want to go into your surgery to stop the spread. When it's smaller, then you can start using your chemo radiotherapy just because it can just stop the area and then it stops any unnecessary surgery, which then can cause damage. So, general rule of thumb is if it's small, then keep to your localized treatment. So, your chemo radiotherapy, which you'll shoot into the area. And then if it's bigger, then surgical excision is your next step.
just give it maybe 1 or 2 more minutes if there's any more further questions. But if not, thank you for joining our session today. Okay, viewers saying thank you. Can you see the chat now, John?
No, it won't come up.
Okay.
I can just see participants, and that's it. Oh wait, no, now I can.
Um, which session was it, Roberto, that you joined? Tuesday. So that would be the cardiothoracic one. Roberto, if you just message us on Instagram, we'll get back to you through that, if that's okay. And we can send you the feedback form if that's the issues. Yeah, cool. Yeah, if there's any other questions, please put them in the chat. If not, the session's finished here.
I'll end the live stream.
Yeah, that's cool.
Yeah.
Okay, thank you, everyone.
Thank you.
Thanks a lot, Johnny. Thanks, Jen.